Hi there, I'm Dr. Janak Chandrasoma, Stanford AIM Lab Fellow. I'm here today at Sol Shnider 2015 in San Francisco with Dr. Craig Palmer, who's a professor of anesthesiology at the University of Arizona, Tucson. You recently gave a lecture on continuous spinal analgesia for laboring patients. Do you want to tell me a couple of key takeaways from that lecture?
Sure. I think the first point that people should understand is that continuous spinal analgesia for labor, it's not a new technique. I mean, it's been around for decades. The first report was over a century ago. It's an excellent technique, provides great analgesia for laboring patients, and it really has very few drawbacks. The biggest drawback is there probably is an increased risk of post-dural puncture headache, but you have to weigh that against all the advantages of the technique, the great analgesia, the flexibility of the technique for extending your block or instituting a surgical block if necessary, and the patient satisfaction level, which is very high.
Dr. Palmer, you were involved in a pro-con debate yesterday. Can you tell me a little bit about each side and which side you were on?
The debate was whether we should relax our restrictions on oral intake for patients in labor. I think for years, literally since the 1940s, the practice of anesthesiologists, obstetric anesthesia in general, has been to restrict oral intake in laboring patients because we were worried about bringing patients who had to come to the operating room and a risk for aspiration. I think that there has been very little evidence over those years that this really is a major problem, aspiration per se. Sure, aspiration does occur. It occurs in all patient populations that we bring to the operating room. It is not particularly more common in the obstetric population.
What exactly do you mean by let her eat cake, which was the subject of your talk?
Right. Well, that's just pretty much a catchy title for the discussion, but I think that most practices, if you look at the ASA guidelines for oral intake during labor, are fairly restrictive. We restrict patients to ice chips, sips of clear liquids, that sort of thing. I don't think that there's any good evidence that if we relax those a little bit, we allow patients to have protein drinks, maybe even soft foods during labor, that they're at any increased risk.
Dr. Palmer, you've spoken a little bit about the types of foods. Now, what about the quantity of food? How much food are we suggesting that we allow the laboring patient to actually consume? How much is too much and how much is not enough? Where do we strike that balance?
This is a wide open area. I mean, there certainly has not been much in the way of published randomized research that would give us a lot of guidance there. So again, I think if we're going to move forward in this area, we have to move forward slowly. Certainly if you're going to allow a little more oral intake, I would think putting limits on it, seeing how patients respond, generating some sort of database, some sort of cohort of patients that have actually, used your technique to see what is reasonable and what is not reasonable, so we can establish those limits.
Thank you so much for talking with us. This has been fascinating.
My pleasure. Thank you.
From Sol Shnider 2015 and from the Anesthesia Informatics and Media Lab, I'm Dr. Janak Chandrasoma, signing off.